Hi everyone, welcome to Hub Bites. I'm Sanil Rege, consultant psychiatrist from PsychScene. Today we have a really special guest, Professor Phillipa Hay, and we'll be talking about eating disorders. Professor Phillipa Hay is a leading mental health researcher and foundation chair of mental health at Western Sydney University. She's committed to research that results in a better understanding of eating and related disorders to reduce the individual, family, and community burden. Her current research focuses on randomized controlled trials of interventions for anorexia nervosa and other eating disorders, as well as public health and community interventions that will reduce barriers to accessing care. Welcome, Professor Hay. Thank you very much for joining us. So I'd like to start off, there's a lot of discussion around eating disorders at the moment. And I'd like to start off with what are eating disorders and how should clinicians conceptualize their classification?
Well, first and foremost, eating disorders are mental health problems. So they're very definitely within the domain of the DSM and in psychiatry. Although there have been, times in the history of particularly of anorexia nervosa where there's been a search for the sort of biological anorexia nervosa. Is it truly a mental health disorder? But I think by and large, we all now agree they are predominantly mental health disorders and they involve a degree of distress and psychological suffering thereby as being part of the spectrum of mental health problems in our community. They're mostly characterized by problems in eating behaviors and what we call eating cognition, so the way people are thinking and feeling around food and eating. The eating behaviors that are most prominent and most well known are those related to anorexia nervosa and bulimia nervosa, behaviors such as self-starvation and doing extreme things to control weight and shape concerns, and anxiety about gaining weight. So, for example, making yourself sick after eating or using a lot of laxatives to purge yourself of food that's been eaten. But in addition to those sort of weight control behaviors and concerns about weight and weight gain, there's also a range of behaviors which are more driven by mood and emotions and a way of self-regulating those. And particularly binge eating is now recognized as probably being on that spectrum of behaviors that's driven perhaps as much by the effects of self-starvation and extreme dieting, which we know can lead to overeating and binge eating, but also as a way of attenuating or managing negative emotions and negative self-regard. But they're intertwined, and really people get into vicious cycles of behaviors, thoughts, feelings, and emotions which perpetuate on themselves, and that's what begins the pathway into an eating disorder, but then maintains the eating disorder. And in some of our treatments, very much there's also a focus on those maintaining factors for the eating disorder. So if you binge, then that drives a sense that you need to get rid of the food, and therefore you may purge or vomit or engage in extreme weight control behaviors like fasting or exercise. And then that you feel worse about yourself for having done those things. And also then you get hungry because you've purged and you're trying to vastly restrict the amount that you're eating. And then so you're more likely then to binge eat. So that's really how we sort of conceptualize and understand eating disorders currently, is that sort of cycle of certain eating behaviors, certain eating thoughts and feelings and emotions. However, in the DSM revision that came out, the DSM-5, the most recent one, 2013, we had a very interesting move away from eating disorders where the core sort of psychopathology and understanding was related to body image concerns, to also some new eating disorders where body image concerns are actually not part of the diagnostic criteria. And indeed, binge eating disorder is not defined by any degree of concern about weight and shape, although that's very, very common. At least 50% of people with binge eating disorder do have weight and shape concerns. But we also have another feeding and eating disorder. And as part of this revision, the whole sort of grouping of eating disorders was renamed feeding and eating disorders. So we have a new feeding and eating disorder called OSFED, or avoidant restrictive food intake disorder. And that is actually characterized by not having body image concerns, but having a dysfunctional relationship with food and eating to the point where someone may be undernourished or malnourished. So they may be deficient in certain nutrients, or they may be undernourished and actually underweight and present in a very similar way to sometimes if people present with anorexia nervosa with problems with low weight, but not body image concerns. And they are often have a problem with food and eating in relation to anxiety, concerns about taste, texture, quality of food, fear of choking, fear of swallowing food and choking on it, for example, not uncommon. So there's a large degree of anxiety driving the way people are relating to food and eating as well in ARFID, or avoidant restrictive food intake disorder. But it's such a long name that we're currently calling it ARFID, and hopefully it may get a better name in the future, because to have an acronym to say the name is not good.
And with regards to, you talked about anorexia nervosa, bulimia nervosa, binge eating disorder, and then ARFID, of course. But there's also there's discussion around muscle dysmorphia and orthorexia.
Yes.
These terms sort of also becoming more popular. Where do they fit in, and what are they in a way?
Yes, well, we're at a very interesting time. As I said, the shift in feeding and eating disorders has moved away from that sort of core body image concerns as being part of all eating disorders, or part of all feeding and eating disorders. But you're right, there are other disorders of body image concern, of heightened body image concern, body dysmorphia, which is a particular part of the body, like your nose or your ears, that people have extreme concern about. But muscle dysmorphia, which currently is classified with the body dysmorphic disorders and the sort of anxiety disorders, but muscle dysmorphia is very like eating, the body image concerns we see in people with eating disorders, because it's not just a particular part of the body, it's all over the body. People are trying to bulk up, be larger, be stronger, be more muscular, and it's much more an overall body image concern, as we see in people with eating disorders such as anorexia nervosa and bulimia nervosa, where people want to be all over, a lot thinner and less body fat. So a lot of research around how similar muscle dysmorphia is to other eating disorders, and debate is, should it be sort of shifted into the eating disorder realm and away from those more specific body parts types of disorders, because people with muscle dysmorphia in many ways are very like people with eating disorders. They have a difficult relationship with food, with eating, with their body image, and they engage in behaviors, extreme behaviors, such as we see in people with bulimia nervosa and other eating disorders. They may take steroids, for example. They may not be using laxatives, but they're using steroids. So they may be using certain substances, but in order to change or manage their overall anxiety about their body shape and also sometimes weight too, but overall body shape is what it's called muscle dysmorphia. So in many ways, they are very similar, and approaches or therapies that may be helpful for people with eating disorders probably can be easily adapted to people with muscle dysmorphia type disorders, and that sort of wanting to be over bulking. There is also some research around, is muscle dysmorphia sort of like the variant of eating disorders that men get as versus the variant that women get. But indeed, the more research that we're doing, and we're doing some studies in a large sample of adolescents in New South Wales at the moment, the more research we're doing in young people, we're finding out that actually girls also sometimes want to muscle bulk as well, and boys also want to be lean. So it's not a pure, this is what boys get, this is what girls get. There's definitely is an overlap between the genders as well for muscle dysmorphia and the sort of more lean concerns that we see in more people with anorexia nervosa and bulimia nervosa in the classic sense.
Right. And orthorexia?
Orthorexia, that's another really interesting one. Now, orthorexia, unlike muscle dysmorphia, which is sort of in the DSM, is recognised as a mental illness, orthorexia is not in the DSM, so it's not an official mental illness, but there has been a lot of research and clinical experience emerging, particularly in the last decade or so, about orthorexia as a phenomenon. And it's a phenomenon that's driven by a desire to have a healthy eating. So like other eating disorders, people are preoccupied with eating, but they're preoccupied with eating the concern is not so much overall shape or weight or wanting to be muscular. The concern is wanting to eat healthily, to have a healthy diet. So that diet becomes extremely restrictive and disruptive to the person's life, to the way they're relating to other people. I mean, the core thing about eating disorders is that in our society, we need to eat. And eating is very much part of the way we relate to other people and the way society functions. And I come from New Zealand, and in New Zealand, if you had a event with Maori people on a marae, you always had to sit down and have the kai first. And you didn't have the meeting until you'd eaten together. So that's just an example of how eating and being with people around food is such a core thing to the way we relate. So not only do we need it to nourish our bodies, we need it to live in society. So people with orthorexia, in the same way as people with eating disorders, also have that problem of it impacting upon the way that they relate to others in their society. But it's also, people say, but you're wanting to eat healthily, so that's what we're all meant to do. And there's a lot of positive reinforcement of that in our society, and belief that people should be eating in that way. And indeed, there was a very interesting study came out in China last year in the International Journal of Eating Disorders, which showed that the people who had orthorexia or orthorexic behaviors and attitudes and beliefs about food and eating appeared to be more adaptive and more functional and living, a more sort of positive life in terms of their mental health and better mental health well-being than people without orthorexia. So it's probably on a spectrum, and at an extreme spectrum, it becomes a problem, but that's the extreme end of those types of behaviors. And similar to compulsive exercise, exercise is something we do for health. It's something that's very good for your mood. It's also very good for your body and your heart, etc. And in fact, general practitioners often prescribe exercise for people with low mood or depression because it does lift mood. But to an extreme, overdoing it, it can become a problem, and it starts to resemble a variant of eating disorders. And we see that in young women who develop problems very similar to women with anorexia nervosa. They may stop having periods, for example. They may lose a lot of weight. They may become underweight, but they may exercise to the point of injuring themselves or continue to exercise when they should stop and rest, etc. So that's where it becomes a problem. And I suspect orthorexia, like compulsive exercise, will turn out to be a variant of eating disorders, but also on a sort of spectrum from a healthy way of being, a healthy way of eating, to an extreme way that becomes rigid, becomes compulsive. And in the same way as compulsive exercise, people become so addicted. It's almost like an addiction. They can't vary it. They cannot do any less exercise. And we've been involved in a psychological therapy for compulsive exercise to try and help people who have to exercise every day for 1.5 hours in a certain way, just to vary that, just to exercise for 1 hour and 15 minutes rather than 1 hour and 30 minutes, to have a better relationship with exercise and engage in social exercise. And people with eating disorders, we also have that sort of approach to the exercise when it becomes compulsive and maladaptive. So encouraging, playing a tennis game or joining a netball team rather than solitary driven compulsive exercise, which can become something that people become extremely distressed about and have to do, and in a way it's almost like it's an addiction. Yeah.
So would it be reasonable for clinicians to expect, as part of within the eating disorder realm in a way, because we've talked about eating disorders, there are, you talked about feeding disorders, and then there is often the comorbid aspects of, say, exercise or relationship with food. So is it possible to just have one aspect of it, say compulsive exercise, resulting in, significant weight loss without the food aspects, that still would come within the realm of eating disorders? So does the treatments still apply?
Yeah, I mean, what I didn't say was that not everybody meets sort of the DSM criteria for a main eating disorder. So, and this is true of the international classification, the World Health Organization classification, ICD-11 as well. We still have this group of what we call other specified feeding and eating disorders. And in the DSM, there's actually 6 that are specified, and then you have unspecified feeding and eating disorders. So you have people who don't meet criteria. They may have high levels of compulsive exercise, they may have weight and shape concerns, but they don't quite fit into anorexia nervosa, bulimia nervosa, or binge eating disorder. But we can make the diagnosis of an other specified feeding and eating disorder or an unspecified feeding and eating disorder. And indeed, we can obtain treatment, and the treatments will work for these groups of people as well. And the other specified feeding and eating disorder, there's an important one, which is called atypical anorexia nervosa, which is a very difficult name, and people with the lived experience of eating disorders do not like the name because it sounds like it's somehow atypical or strange. But in fact, what it's saying is it's people with anorexia nervosa who are not clinically underweight. So they have been perhaps at a higher weight, lost a lot of weight, are in a starvation state, have all the symptoms and the experiences of someone who is underweight with anorexia nervosa, but they are not clinically underweight. And we are seeing more and more of those people now coming through, particularly as the sort of problems of high weight are increasing in society, and also the sort of approaches to high weight and the sometimes very extreme weight loss that people may have, for example, following bariatric surgery, where people then get into a state of anorexia nervosa. So that's an important one, which is increasing, and we are seeing more of in the other specified feeding and eating disorder categories. And another one is night eating syndrome, where people often may actually don't present to necessarily psychiatrists, may often present to sleep clinics because it's occurring at night. But it just seems like it's a sleep disorder, but it's people getting up after going to sleep in full consciousness. It's not like sleepwalking, there's no altered consciousness, but having binge eating episodes, which are exactly the same really as people with binge eating disorder or bulimia nervosa. So eating large amounts of food over which they have a sense of loss of control, that they can't stop, can't prevent themselves from eating, but it's all occurring at night. Now, in some of our research, we've found about 50% of people with night eating syndrome also have day eating, binge eating. So they would have the diagnosis of binge eating disorder with night binge eating. But there are a substantive number who just have the night eating part of it. And that's one of the other specified feeding and eating disorders. And then there's also purging disorders, who are people who just have extreme weight control behaviors, making themselves sick after eating or using laxatives or compulsive extreme exercise, but they are not binge eating in the same way as people with bulimia nervosa are. So it's not just following and eating a large amount of food and loss of control eating. So that's not that common, probably one of the less common, but it does occur as well. So people can be certainly probably diagnosed, and if all else fails, under the unspecified feeding and eating disorder category as well.
Right. I mean, it's interesting because there's so many sort of facets to this, and often right at the fore of our mind, and particularly through training, we often tend to think about anorexia or bulimia as sort of a dichotomous one. Binge eating has probably become more common sort of in terms of because of training, etc. But many of these other ones probably fly under the radar in general, in general practice, and so primary in psychiatric care, I would imagine as well. I'm just thinking in terms of the genesis of eating disorders, considering the biopsychosocial, cultural diet lifestyle model. Firstly, starting off with sort of gender, would it be true to say that there is a female preponderance for eating disorders as a whole? And if yes, what is driving that?
Yeah, I mean, there is. It does vary across the eating disorders. And the classic eating disorders, anorexia nervosa and bulimia nervosa, it's about a 10-to-1. And that seems to have been consistent for, as long as people have been looking at it, really. But it's still 1 in 10 are men. So it's still, men still occur. With binge eating disorder, with other eating disorders, it tends to be more men and what we call a large minority of men. So over all the eating disorders, we would say 30 to 40% maybe men overall, but a minority, still a minority, but a more substantive minority than sort of 1 in 10. Right. So to answer your question, the short answer is yes, it's still predominantly a female disorder, and lots of speculation, lots of thoughts, lots of research around why that is so. Is it that women develop eating disorders when they don't develop other things? Men are more likely to develop substance use disorders or other disorders in terms of managing mental health states and having a mental vulnerability. Certainly there's probably a societal aspect for sure. And in our society, the pressures to be a certain body shape or weight or eat in a certain way seem to be greater for women than for men, and particularly for young women. And we know that the origins, the time when people are most vulnerable to develop an eating disorder are in those very crucial early teens, mid-teen years when the body is changing rapidly. People are becoming aware of themselves, their sexuality, who they are, and heightened sensitivity to comments and to events that happen in their lives. We know that there's actually very interesting genetic and environmental interaction at that age, that people who otherwise have a heritability towards eating disorders and have things happen at that time of life which are what we call invalidating experiences or things that are traumatic or just even critical comments. And it can be as simple as, the class being weighed and you were the girl in the class who was weighed and you were the one that stood out, those sort of things happening at that vulnerable time. But there's that interaction effect between the sort of genetics and the environment that gives rise to eating disorders, which most commonly have their origins in those mid-teens, later teens, and then into the young adulthood years. And we know that for women as well, there's another time that's also vulnerable, which is in the perimenopausal, again, a time of body change and also perhaps life events, life experiences, and where the self is sort of reappraising yourself, reappraising your life, your values, and a vulnerability, time when people are more vulnerable.
Interesting. So if we as clinicians have to think about an assessment, what would be the red flags that we clinicians should think about that sort of prompts us to think, okay, I think we need to go deeper into this when the patient doesn't necessarily present with it, because most of the times patients may be guarded. What are the red flags for clinicians to think about?
Yeah, well, anybody presenting with concern about weight, and that no matter what their weight is, whether they're underweight, adequate weight, or high weight, if they're presenting and asking for help or have concerns about weight, that's the most common time that people with an eating disorder will interact with their family doctors, is around weight. So anybody, obviously also there's a high rate of comorbidities, and eating disorders in themselves often give rise to distress, depression, mood changes. So people presenting with other mental health problems, but particularly depression and anxiety, just always think about, could there be an eating disorder as well that's occurring? And people presenting with unexplained problems, perhaps of low potassium if they are vomiting, or low blood pressure, postural hypotension, that maybe may seem unexplained or unusual, then think about it. There are obviously some populations who are more so young women. One should be thinking about it perhaps more than other ages, but also think about it in young men as well. And I guess just have it there as a possibility. So as I say, anybody presenting with sort of unexplained other problems that we wouldn't really expect.
With regards to screening, would it be reasonable to have a question, just like we ask about mood, and we ask about anxiety, would it be reasonable or an important aspect for clinicians to ask the question, do you have concerns about your weight, as a screening question for patients? Or are there screening questions in your mind that could help?
Yeah. I would say, do you have a concern about your eating?
Right.
Have you had any issues with your eating? Because everybody's had issues with their weight. Weight concern is so prevalent in our society. And again, some of the research I've done, which has shown that, at least 50% of the population have a quite considerable degree of weight and shape concern if they're asked about weight and shape issues. But asking people just about their eating is a much better way of asking it. Often asking about weight is very triggering, very upsetting, very distressing for people with eating disorders. But asking about their eating is really important and something that they're often very relieved to talk about. And that many people, particularly with binge eating disorder, had not realized that it is a mental health problem that's treatable and that we can diagnose and offer evidence-based treatments for. They just think that they're lacking willpower, they have this loss of control over eating, they're a bad person, often a lot of negative self-view around the binge eating. So to learn that it is a problem for which there is recognized solutions is often a great relief, and people are often very relieved to talk about it. But I certainly wouldn't ask people about their weight. I'd ask them about their eating, their mood, their relationship with food, and just ask straight out, do you have problems with loss of control over eating? Or ever feel that your eating is something that's causing you a problem, causing you distress, that you can't eat around other people. A lot of people with eating disorders stop eating socially and become very socially avoidant, particularly around any eating time, so that they eat in secret. So is eating ever a problem that you might eat in secret or want to hide or do away in a solitary way? Hiding food, that sort of thing.
That's really helpful. So to sort of summarize questions around, do you have any concerns around your eating? What's your relationship like with food? Do you ever feel, you lose control when you're eating? Those sorts of questions potentially could be helpful in veering away from the weight, because again, it might not be a sensitive question in the sense of picking up aspects, because the large proportion of individuals often do, but I guess it could be sensitive in the sense of people may not respond very well to that question.
And for someone with an eating disorder, if you ask them about their weight, they then think, you're saying I'm fat. I must be overweight. I must be looking large to you. Very, very sensitive to any sort of comments or inquiry about weight. Or the other way, people say, oh, you've lost weight, and they think, oh, that means I must need to lose more weight. So it's often not helpful.
Yeah, that's a really important point. Thank you for that. I'd like to focus a little bit more on anorexia nervosa initially. That often it's talked about as a Western illness. With the societal perspectives of some of these things you mentioned. What are your thoughts about that and cultural aspects in general as well?
Yeah, it definitely is a disorder that was more common or more prevalent in what we call westernized societies, certainly throughout the 20th century. But with the end of the 20th century, fall of the Berlin Wall, Eastern Europe coming into Western Europe, the rise of middle classes in the Indian subcontinent and in South America, we see eating disorders all around the globe now, and certainly anorexia nervosa all around the globe. There was a time when in some cultures that there was the sort of syndrome of young women with states of self-starvation, really managing their mental health state with self-starvation, but not ascribing to a fear of fatness or such concerns about body image as were seen in young women with anorexia nervosa, say in North America or Europe. But with the sort of westernization, if you like, of Hong Kong and now also of China, they're also talking about fat and anxiety about fat and fat phobia and body image concerns that are the same. So probably for centuries and for as long as we know. We haven't got a lot of information going back, but we certainly have information going back hundreds of years into sort of European culture. We know that in the Middle Ages, that young women who often they were very religious, they may be nuns, they were often entered in states of self-starvation. And actually, Catherine of Siena, who's the patron saint of Italy, was a leading religious woman in medieval times who died in a state of self-starvation and wrote about it. She probably had a form of anorexia nervosa, but it wasn't a form of anorexia nervosa that we would recognize today because it doesn't have this overlay of the thin ideal that is probably part of our culture, our current culture. So self-starvation and having a difficult relationship with food and eating and using food and eating way of modulating negative emotions, that's probably been around for a long time. But the presentation, the sort of phenomenology of someone with an eating disorder today is probably coloured and is probably made more prevalent because of societal beliefs and attitudes towards body weight and shape. And in the same way as we're now seeing the bulking and the increased muscularity, that's really quite striking in our culture. That does seem to be a phenomenon of, again, late 20th century, early 21st century, for young men and women to be bulking in such dramatic ways and to use steroids to bulk up. You know, that's very much part of our culture. So there is this cultural overlay, but again, there's sort of problems relating to food and eating and one's mental health status has been there for a long time as well.
Right. So talking about, you mentioned the phenomenology of anorexia nervosa. What would be the main sort of clinical features and the diagnostic assessment for clinicians that we need to focus on? And you're of course the main author as well of the RANZAP guidelines on eating disorders as well. So we'd like your insights on the clinical features and the diagnostic aspects of anorexia nervosa.
Well, the core clinical feature of anorexia nervosa is a state of extreme restriction, so food restriction, and therefore sometimes purging as well to get rid of food. So there's both people may just be purely restrictive, maybe with compulsive exercise, or they may have purging behaviors as well added into that to try and maintain a weight that's lower than is healthy for them, that is adequate to meet their nutritional needs. So that's the thing that really sets anorexia nervosa apart from other eating disorders. But like other eating disorders, people with anorexia nervosa have what we call overvaluation of weight and shape. So their body image, the way they think and feel about themselves as a person is tied up, their identity is tied up with weight and shape issues. So if you ask someone with an eating disorder, what are their important issues? How do you evaluate yourself as a person? What gives you a sense of self-confidence, of good self-esteem? And someone might say, well, it's my relationship with my family, it's being a good mother, it's being a good father, it's being a good person at work, being successful in the way I work. That's how I really find my sense of self and identity and self-view. For someone with an eating disorder, it's weight and shape become, if not the most important issue, at least one of the most important issues to the way they think about themselves and value themselves as a person. So that's at an extreme level. And that with the extreme dietary restriction behaviors of people with anorexia nervosa are really the core features of that. Now, alongside that, of course, are other body image concerns of preoccupation about food and eating, not being able to concentrate at work because you're thinking about the next meal, or not thinking, or trying to think about not having the next meal, for example. So thoughts, preoccupations around food and eating, and also around body weight and shape. And sometimes that leads to or goes alongside behaviors that reflect that preoccupation and may seem to be like the sort of behaviors you might see in someone with an obsessional disorder. So a lot of repeated body checking, measuring your waist several times a day, or again and again, weighing yourself again and again, and not being reassured by that weighing, so becoming more and more anxious. And one of our assessment instruments, the eating disorder examination, has a question about asking, how would you feel? Would you be able to cope with the anxiety if you were asked to weigh yourself only once a week for the next 4 weeks? And that's only once a week. So either it's very distressing to weigh yourself and you've not been able to weigh yourself, or you need to weigh yourself every day, several times a day, and you couldn't limit that to once a week. So those sort of behaviors, thoughts, and feelings also around weighing, around food, around eating are clinical features, things that we see in people with eating disorders, but particularly with anorexia nervosa.
And how would that be different from someone with bulimia nervosa and binge eating, if we sort of move towards the other two?
Yeah. Well, there's a lot of overlap, but the distinguishing feature is that people with bulimia nervosa and binge eating disorder are not clinically underweight, and they have regular episodes of binge eating. So, and that binge eating is characterized by unusually large amounts of food over which they have a sense of loss of control. But also people with anorexia nervosa can have binge eating as well. And that's the binge eating purging form of anorexia nervosa. So it's very confusing. And I often have people who come to see me and they say, well, I have bulimia, but they have a BMI or a body mass index of 13 or 14. So they clearly have anorexia nervosa, but they have the binge eating purging form of anorexia nervosa. So but people with binge eating disorder, bulimia nervosa, are of adequate weight or high weight, and they aren't, that's really that they're not clinically underweight, but they are very, share a lot with people with anorexia nervosa, and that self-evaluation of oneself around weight and shape is something that people with bulimia nervosa very definitely share with people with anorexia nervosa.
Right.
And people move between the disorders as well, just to make it even more confusing.
Yeah.
A lot of people, about a moderate proportion of people with anorexia nervosa do develop bulimia nervosa in recovering from their eating disorder, or at the stage of recovering from their eating disorder, and also the other way around. And increasingly these days, we're seeing people who may have anorexia nervosa, but with some degree of recovery, but also develop binge eating, develop bulimia nervosa, and then may start to recover or change their eating behavior. So it's purely binge eating, then they develop binge eating disorder. And I've seen people move the other way as well. So just to say, they're not, over someone's course of an eating disorder, they may actually experience or fall into different diagnostic groups. So clinically, really we think of them as eating disorders, and then what are the main characteristics for that person of that eating disorder at that time, and then you make a specific diagnosis of anorexia nervosa, bulimia nervosa, or binge eating disorder, or another eating disorder.
Yeah. And with regards to, I think importantly, when as clinicians, we might not specialize in eating disorders. So I guess the recognition that there may be an overlap, there may be atypical features. So being sort of accepting that we might not be able to make a diagnosis conclusively, and that little bit of uncertainty is okay, and putting the right steps in place, which we'll discuss in a bit, can still sort of work well from a primary care level, but also I think private practice in psychiatry. Now, anorexia nervosa, we know, is one of the illnesses in psychiatry with a very, very high mortality rate, and it's one of those things. When I was reading about it, it's striking, and sometimes it's not something that's well known. So just like you to talk a little bit more about the mortality side of things and the medical aspects, and what should clinicians really be doing in the outpatients.
Yes, it does have a mortality. And for young women with mental health problems, it probably has the highest mortality of mental health disorders. And there's a variant, what I call them as a malignant form of anorexia nervosa, of people who do not recover easily or engage easily with treatments who develop a chronic form, a persistent form of anorexia nervosa, and that has a very high mortality. So overall, it's always there. You always think about it. In terms of treatment and what clinicians should do, I think you've got to realize this is a disorder where there is that physical health comorbidity, there is a mortality. You need to be working with a physical health specialist, either a good GP or a good physician who's understanding, supportive, empathic. You can work together as a team, and often also with a dietitian as well for the nutritional aspects, nutritional counselling. Refeeding is a science to itself, is complex. It can have some risks in terms of refeeding. Often we do, therefore, do refeeding in hospital settings or in more intensive treatment settings. We can do refeeding as an outpatient, but that tends to be the people at the sort of higher weight end of the spectrum and who are less severe anorexia nervosa. And we would go much more cautiously as well in terms of the rate of refeeding in an outpatient setting. But most, very often it's done in an inpatient setting with, good physical supervision as well. And unfortunately, sometimes people do need to be admitted medically prior to engaging in a psychiatric admission, just because they can present in such an unwell state with anorexia nervosa. So that's part of it. I mean, it's certainly part of where you can't be a psychiatrist and throw away your stethoscope. And and also in this day of Zoom and phone, I would say eating disorders are not good disorders, particularly not anorexia nervosa, to do where you on a phone where you cannot see someone. Preferably, obviously, in person or someone seeing them in person, and also monitoring their physical state. And that particularly, obviously, weight is often the thing we think about, but it's actually more than weight. It's your physical state, it's your cardiovascular state. And really, anybody in a state of anorexia nervosa and starvation is in what I call a compromised cardiovascular state. They have a slow pulse rate, they have often small, weak hearts, often low blood pressure, and they're very vulnerable. And if there's something happens that something physically happens, like an infection, they're very vulnerable to an overwhelming infection or pneumonia, or just a sort of rapid destabilization of their state. So if they're rapidly refed or rapidly rehydrated, they can go into heart failure because the cardiac state just really can't take it. So that's something to be always very aware of.
Yeah, and I think in the guidelines, you've specifically, the group has put down indications for inpatient admission as well, with not just BMI as a parameter, but also looking at pulse and blood pressure and postural drops and ECG and potassium and magnesium, etc. So quite a few, and the psychiatric components being separate. In terms of treatment, the evidence-based treatments for anorexia, what works?
Actually, we have a lot of treatments that work, and that's been reflected in the government's Medicare funding for psychological therapies. And it's been very striking that with anorexia nervosa, we know that what works is a eating disorder informed specialist therapy, psychological therapy, that's done in conjunction with attention to nutritional state and medical and nutritional needs. But we have a number of those. The one that most thought about is cognitive behaviour therapy, and there's definitely been cognitive behaviour therapy that's been shown in randomised controlled trials to be very efficacious for people with anorexia nervosa. But we also have a therapy that came out of the Maudsley Hospital in London for adults with anorexia nervosa that looks more at the cognitive interpersonal style for the person and lots more at the way they perceive and relate to other people. So it's derived from a different model. And we have a therapy called specialist supportive clinical management, which is good clinical care combined with supportive psychological therapy and goal setting, target setting for making changes in both your ways you sort of perceive and relate to yourself and your eating, but also in your interpersonal life and in sort of quality of life changes as well. For children and adolescents, we have family-based treatments, which are manualized and which have been developed into variations. So some of them, sometimes the family may be seen separately or the parents may be seen separately from the child, but they're all involving families and family eating and sort of relearning to eat again within the context of the family environment. A good evidence base, a lot of randomized controlled trials showing that these work well, but none works clearly better than the other, particularly in the adult domain, which has been a really interesting thing. So we're now very interested in thinking about, well, what's working for who, and can we tailor the treatments for the person more, because we know that there's a range of treatments that do work. Another one is focal psychodynamic psychotherapy, which of course is something that's taught widely and expected for psychiatrists in their training in Australia. So that, again, a very large study done in Germany where they compared focal psychodynamic therapy with cognitive behavior therapy for anorexia nervosa.
Right. And is there sort of a dichotomy in the sense of, inpatient being better or outpatient or community? Because sometimes, I've heard saying that sort of very restrictive settings may actually be detrimental, or an eating disorder unit may not be ideal. And of course, the medical side taken away, but from a psychological perspective, because patients may learn maladaptive behaviors, etc. So, how do eating disorder clinicians think about this treatment approach?
Yeah, I think what we've largely found is that the majority of people can be treated as an outpatient, and we have, as I say, a sort of a repertoire of psychological therapies that we can offer in an outpatient setting, most usually in conjunction with a general practitioner or physician and dietitian, to sort of have a team working with the person as an outpatient. But there are people who are more unwell, more in need of help, particularly of meal support and supervision and encouragement and around food and eating and meals in particular, who do benefit from more intensive care in a day program or partial hospitalization, or in we now have residential programs being developed in Australia. We've had one started on the Sunshine Coast with the Butterfly Foundation, or in an inpatient, full inpatient setting, mental health setting. And but they are part, I tell people, they're part of the journey of recovery. We don't admit people to hospital and keep them there until they're recovered anymore. That might have been the way 20, 30 years ago, where you admit people for a year or 2 years, but we don't do that currently, because what we've found is that then people disconnect from their family and their friends. They become more, they lose time. They lose, often children, adolescents would lose time at school, etc. And as you said, there's some detrimental effects as well in terms of losing a sense of autonomy and a sense that they are empowered and they are part of the solution rather than the sort of treatment being imposed on them. So we tend to keep those, any sort of more intensive treatment time to a minimum, as not over brief, obviously. There has to be a certain number of weeks, often between 4, maybe 8 weeks, but as part of the journey, because the journey of recovery from anorexia nervosa is usually, we're thinking in terms of months and sometimes years, particularly for adults. More so than perhaps for children and adolescents. We may be thinking more in terms of months, but maybe longer. So it's part of the journey of recovery. There were programs which are really, I think, should be in the sort of history books now, the very punitive behavioural programs that were very popular in the 70s and the 80s. I think they did do harm, for sure, for people, where you had to sort of eat your way out of hospital, and you had to sort of eat to get privileges and rewards and etc. And they certainly were very punitive, very demeaning for the person. And you got to remember, people with eating disorders and anorexia nervosa often don't feel good about themselves as a person anyway. They often have a very fragile sense of self and low self-esteem, and you put them in a very controlling, punitive environment where they're made to feel even worse about themselves. That certainly had the propensity to do harm. So those kind of programs, I would hope, are now historic, gone. And what we do is we try and engage the person in a very collaborative way, and we bring people into a more intensive treatment setting as part of that journey and as part of helping them support and recover from the anorexia nervosa, and facilitate that recovery with more intensive support and more 24-hour therapy, availability of nurses, staff, availability of psychologists and people to support them in a more intensive environment, psychological environment.
Thank you for that overview on psychological treatments. In terms of medications, are there any medications that work or are evidence-based in anorexia nervosa?
Not so much really in anorexia nervosa, although there have been a lot of trials and a lot of attempts to see whether do antidepressants help, do antipsychotics help. Probably what the sum is that the very little amount of evidence there is that some low-dose antipsychotic medication is helpful, particularly in the early stages of treatment where there's maybe a lot of distress and a lot of arousal and a lot of anxiety. The brain is really sort of firing all up with fear and anxiety around the food, the eating, the refeeding, etc. So there is a little bit of evidence, but it's very weak for anorexia nervosa. We have much better evidence for medications in bulimia nervosa and to a degree also in binge eating disorder. We know that high dose SSRIs like fluoxetine, 60 milligrams a day, helps reduce binge eating episodes for people with bulimia nervosa and probably binge eating disorder as well. We know that some medications, also other medications, may be helpful. There's an anticonvulsant pyramate which has been trialed, but it is quite poorly tolerated and has adverse effects, particularly neurological effects and sedation. And there is one drug, lisdexamfetamine, which is actually approved. We actually only have one drug approved under the TGA for eating disorders in Australia, and that's lisdexamfetamine, which is a stimulant which, if your psychiatrists are familiar to its use in ADHD, will be familiar with it as well. But it does seem to help reduce binge eating episodes. But on the whole, medications play more of an adjunct or supportive role for primarily treatments are psychological therapies. But they are there and important to think about and use when appropriate.
Interesting. And it's interesting that from a medication perspective, that anorexia, we don't have so much evidence, and then for bulimia we have serotonergic agents, and then anticonvulsant, and then for binge eating disorder we have agent that increases dopamine and noradrenaline. So it must be something about the underlying biology, neurobiology, that makes them quite distinct. I'm just interested in some of the challenges that clinicians face from a medico-legal perspective, particularly when it comes to anorexia nervosa and refeeding. I was just wondering whether you could sort of give us some insights on the medico-legal landscape around this aspect. Yeah.
Well, the bottom line, I think, is that anorexia nervosa is a mental illness and a severe mental illness with it, as you were talking about earlier, significant morbidity and mortality. So in my book, one can use, as one would with any other mental illness, sometimes legislation or mental health act to assist people in terms of recovering and in terms of managing when there's a crisis, when there's a high level of medical and psychological risk for the person. So if someone comes into hospital and is in a heart failure or physically unwell and has anorexia nervosa and needs to be in hospital and often might need to be in intensive care not uncommonly, then I think it's appropriate to consider that as in the same way as you would another mental illness, that one must help that person and treat that person, albeit it may be involuntarily. But it varies around Australia as to how you might use the Mental Health Act to do that, whether you might go to guardianship board to do that, or duty of care, perhaps at the last resort. But there are alternatives sometimes to the Mental Health Act. Sometimes they may not seem to quite fit the Mental Health Act because of don't have clear-cut delusions, hallucinations, etc. Yeah. So, but certainly in my book, but I always think one should do that in as much as possible in a collaborative way with the person, agreeing with the person that maybe we're agreeing to disagree at the moment, but this is what we need to do to help you at this point in time, with a view to going as quickly as possible towards less restrictive care. And as I said earlier, people with eating disorders and anorexia nervosa often have such a low sense of self-worth that you should do everything possible to support them, support their autonomy, support their sense of not having everything taken away, and always offering people some choices. And Josie Geller from Vancouver in Canada is very much, she said, no matter what, there's always a choice. There's some choices you can offer people to give them a sense that they still have a sense of being respected by the caring physicians. And it might come down to the choices between a particular way that they may be being refed at the time, between maybe gastric or oral feeding, or just some degree of choices and engagement in the process or in the treatment, so that there is that sense that it's still to a degree collaborative and minimizing, and for as short a time as possible, care under an involuntary order.
Yeah, those are really helpful insights for clinicians on the ground that might not have experience with eating disorder in general. With bulimia nervosa, you cover the psychological interventions for anorexia. Are they similar for bulimia nervosa as well, the psychological interventions?
Yes, I mean, it's interesting. Probably there's a narrower or more narrow repertoire. Cognitive behavior therapy, very definitely the leading therapy. Large number of randomized controlled trials been done with cognitive behavior therapy for bulimia nervosa as well as for binge eating disorder. And it's probably the most commonly one that's practiced and then offered to people in an outpatient setting in Australia today. But interpersonal psychological therapy also has a small evidence base, and increasingly dialectical behavior therapy has a small evidence base as well. And there is something about dialectical behavior therapy that really resonates, I think, in caring for people with eating disorders, because you can validate and respect the person's engagement in the eating behaviors. You can understand that they're doing these things which they don't want to do. They don't want to use large amounts of laxatives. They know that that's not something that's good to do. It's something that they feel disgusted or angry with themselves for doing, but they're doing it out of a sense that this is the only way to sort of stay in control of their weight and avoid the weight getting out of control. So that validating that dialectic of both at the one time knowing or disliking or even having disgust and real despair about the behavior, but also needing the behavior as well in order to maintain a sense of mental health equilibrium and feeling positive and feeling in control of yourself and your life. That dialectic and validating that dialectic really resonates. So DBT and elements of DBT, as I say, there is a small evidence base in bulimia nervosa and binge eating disorder, and its use as an outpatient setting is also an interesting psychological therapy to consider.
Right. So one doesn't necessarily have to have the borderline personality structure, so it can be used independently.
Yes, it's been used independently. It's not as intensive as the DBT that's given for someone with borderline personality disorder. It's been trialled as an outpatient form once a week sessions But the same components, that meaning making, the validation, as well as the training and emotion regulation skills, is part of the DBT for people with eating disorders. And indeed, it's actually been trialed as a guided self-help form of DBT for binge eating disorder and eating disorders, and found to be efficacious. So that's interesting. As has CBT, this has been adapted into guided self-help and online versions as well. But DBT very recently has been adapted into a guided self-help form.
So for bulimia nervosa, we've got CBT, IPSRT, and then DBT with good evidence. And for binge eating disorder, so I know for the DBT can be used for the binge eating component bulimia, but for binge eating disorder as well on its own?
Similar psychological therapies, and indeed the leading cognitive behavior therapy is a transdiagnostic therapy developed by Fairburn, and it was trialed across eating disorders. So it also can be used for anorexia nervosa, exactly the same manual, and for bulimia nervosa and binge eating disorder, although for anorexia nervosa, obviously there is that attention to nutrition and restoration of physical state, but it's the same core psychological therapy, and it has additional modules which are sort of added into it. They really aren't CBT. There are interpersonal psychological therapy module. There's a low self-esteem psychological therapy, and a clinical perfectionism psychological therapy module, which are tailored to the person. If they have a high degree of clinical perfectionism, you can use that module, and a mood intolerance module, which is really about emotion regulation skills, as we might do with DBT. So, in fact, the leading CBT has sort of expanded to include these other therapies as well.
Interesting.
Sort of interesting.
Yes, yeah. And just sort of, I mean, that's a lot of information, great insights about, the range of eating disorders. Thank you so much. I think there's a wealth of information here. I wanted to sort of move to sort of general advice. Firstly, we've got subscribers that are general practitioners and psychiatrists, but firstly to general practitioners, what would be your advice, and what do you see their main role in primary care general practitioners when it comes to eating disorders?
Well, general practitioners, they're right in the centre. They are the gatekeepers to Medicare funded care. They're the gatekeepers to specialist care, and often the gatekeepers to referral to specialist eating disorder psychological programs in hospitals. So they're really the nexus of it. And also they're often the primary person who's providing physical care and oversight of the person's physical health status. So really in the centre. And they're the people who are most likely to be consulted and to actually detect and pick up if someone has an eating disorder. So if any GPs out there are listening, just think about people with eating disorders. As I said, think about just asking people about their eating and follow that up with questions. There's a lot of information available on websites such as National Eating Disorder Collaboration, the NEDC, or the Butterfly Foundation website, or ANZ website, which actually tell GPs how to screen, good screening instruments, and also how to refer and how to do a eating disorder treatment plan to access the Medicare item numbers for people with eating disorders, to see a psychologist or to see a dietitian. And that's up to 40 sessions with a psychologist and 20 sessions with a dietitian per year. So it's a good deal. But they, very easy. You just Google sort of NEDC or Butterfly Eating Disorder Care Plan. You can download the entire template and the screening instruments, the questionnaire that needs to be provided, for example. So, as I said, that's really important because they are the gatekeepers.
Yeah, and I think with the Medicare expansion for psychology sessions and a dietitian, I'm wondering, have you seen that uptake? And I'm wondering whether it's fed into outcomes in any way at the moment. I mean, it might be too early to evaluate, but just wondering.
Yeah, well, I think COVID has come in the middle of it as well, which has not been helpful.
Yeah.
In terms of that, we know that COVID has a very negative impact for people with eating disorders, with food insecurity, as well as isolation and all the other mental health impacts. But there definitely has been an uptake, And one role of that is also that you need a psychiatrist to do a review. If you need the 40 sessions, you can get the 20 sessions straight up, but with the GP and the psychologist. But to get the 40 sessions, you need the psychiatrist review. So I do know, I've been doing those reviews, so I know that people are taking it up. I think it's probably too early to tell if it's having an impact, but I can't see how it's not having a positive impact, really, for people with eating disorders. It greatly increases the access to care and as well the longevity of care that people often need. As I said, particularly with anorexia nervosa, you're talking about months or a longer term treatment. And it's really hard to get that without that being, well funded.
Yeah. And you spoke about psychiatrists. What would be your advice to psychiatrists? And of course, also, where the role. There's a range of psychiatrists, range of specialists. Your thoughts?
I would say don't be scared of it. Don't be scared or think, I don't know enough about it, or I couldn't do one of those reviews, so I don't know enough about it. And in fact, you probably do know enough about it. I think most psychiatrists do have those core skills in mental health assessment, mental status assessment. We're also doctors, so we're tuned to physical health status and things. And you certainly probably do know enough about it to do a good assessment and to provide value-added advice to the psychologist and to the GP, particularly around comorbidities. And very often when I'm being asked to do those reviews, it's often to say, well, is there a role for medication as well for this person? Is there depression? We do see low mood and depression as part of the eating disorder, but is there a comorbid major depression or depressive disorder as well that could benefit from medication or other comorbidities that may be present that we can give, good insights and understanding of, and as I say, value add to the person's therapy program. So I would say, don't be scared, step up, do the reviews, get some help, maybe some supervision, maybe with someone a colleague or someone who may have more experience with eating disorders. Talk about it with your peer review group. The ANZIA, the Australian Academy of Eating Disorders, is running webinar after webinar for healthcare professionals to upskill and to sort of come up to date a bit with eating disorders. So there are avenues out there to get some upskilling and get more up to date if you feel, well, I haven't seen someone with an eating disorder for a long time, etc. But I would say don't be scared of it. And actually, the treatments work. We have good outcomes. So it's a very rewarding area to be in because you do actually see people improving. And often when I'm doing, as I say, these reviews, people are quite improved from when they started the psychological therapy. So it's kind of an area where you do see people recovering. And I tell people you can absolutely recover fully from an eating disorder. Absolutely. But most people do recover.
Oh, that's
if
great.
You get the right treatment and engage with it and have that sort of positive treatment experience.
Yeah, that's great to hear because, there does seem to be certain hesitancy sometimes, where particularly with eating disorders. I think it's also because likely through training as registrars as well, the exposure to eating disorders may not be as much as coming to psychosis or schizophrenia or mood disorders. So I'm just wondering in terms of how you see the future and systemic changes or training changes, what are the kind of things that you'd like to happen that could potentially make a big difference to patients with eating disorders from a psychiatric training perspective?
Yeah, well, I think I would like to see all trainees get a broader experience across the board with mental health problems. I mean, I fully think that you must have, really good experience and understanding of the major psychoses and of the major mood disorders. But the major anxiety disorders as well, obsessive compulsive disorder, generalized anxiety, panic anxiety, they're very common, very debilitating, and eating disorders, substance use disorders, personality disorders. So I think I would really like to see training broadened, maybe training. I mean, I certainly think there's great opportunities for training to, if it could be funded and appropriately, supported, etc., into broader areas and into the private sector or into working with psychologists and psychology practices, etc. Just to get that sense, that sort of confidence in the broad spectrum of management for people beyond, as you say, core mood disorders and psychotic disorders.
And with anorexia, it's interesting. I mean, not just anorexia, but I guess with mood disorders and research, you're heavily involved in research. And I was reading a recent study, I think it was just this year, that showed some genetic polymorphisms with sort of metabolic aspects rather than any of the others. So the question is, are we looking at, is this sort of a metabolic disease? And where is research going to lead us sort of moving forward?
Yeah, I mean, that's, as I said, that there was that sort of view that is, I started this talk with saying anorexia nervosa is a mental health problem. I mean, but you're right, there was a large genetic study published in Nature Genetics last year, I think, the year before. Hannah Watson was the lead author. What we do know is that the heritability is complex and multi-genetic, multifaceted. It includes probably heritability around certain personality style and structure, and that very obsessional, perfectionistic, driven, high-achieving personality structure is probably to a degree heritable. But as well, there are certain ways of body habitus types which increase some vulnerability to an eating disorder. Now, for the majority of people with eating disorders, that's a vulnerability to being in a larger body. And in fact, the overlap and the heritability with being in a larger body and with metabolic problems that accompany that, with diabetes and things that accompany being in a larger body and being of high weight, is something that we see very much in people with eating disorders. A lot of people believe in those, but particularly people with binge eating disorder and other eating disorders. However, people with a more restrictive type of eating disorder, with anorexia nervosa, maybe atypical anorexia nervosa, and some people with bulimia nervosa who are highly restrictive, there seems to be that heritability around a lean body type, and an ability to actually be over-controlled in terms of eating, and that probably goes with that perfectionism and a sense of being in control through the eating disorder and having control over your weight, your eating, etc. And having that sort of propensity towards being lean, less likely to have those metabolic problems, etc., that we see in sort of associated with high weight. So I think, I don't know, one should never make predictions, but we might be seeing eating disorders kind of split along that kind of biological vulnerability into the sort of the highly restrictive, perhaps over-controlled, over-perfectionistic, as opposed to the less restrictive, more likely to be associated with binge eating and a higher weight end of the spectrum. And that's what I think that paper really said, was really saying. I thought it's a big leap to say it's a metabolic disorder. And personally, I don't think we're going to find it's a metabolic disorder, but I could be wrong.
Interesting times. Yeah.
Many people spent a lot of time in the 20th century looking for the endocrine problem.
Of course.
And
also, I think in some of the other aspects, and of course we'll wrap it up soon. But there was this discussion around. I sort of asked on social media. I'm interviewing Professor Phillipa Hay. What are the questions you'd like me to put forward? And there were questions around the overlap between anorexia nervosa and autism spectrum disorder and ADHD as well. So I'm just wondering, is there an overlap? What do we need to know around that aspect?
There is certainly a comorbidity, a co-occurrence of certain eating disorders are more likely to co-occur with autistic spectrum disorders, probably the restrictive anorexia nervosa type, or people with the obsessional personalities, or people who have we call difficulties with emotion, responsivity, emotional empathy, understanding mirroring emotions and understanding other people's emotions. And we definitely see for some people with anorexia nervosa a high level of what we call alexithymia, ability to actually relate emotionally to other people. That is, obviously somewhat akin to what we see in people with spectrum disorder as well. There is, but they're not one and the same thing.
Yeah.
So I think they are distinct disorders. And although there is that, you can have shared vulnerabilities, shared personality vulnerabilities, personality structures that can be shared, but it doesn't mean they're one and the same disorder. But there definitely is that comorbidity, and is seen, and particularly with people with anorexia nervosa and people with autistic spectrum disorder, autism.
Great. Well, thank you so much for your time. That was absolutely fascinating. So I take the opportunity to thank you. Thank you so much for giving up your time to share your insights. Of course, with regards to this channel as well, do subscribe to, that we have the newsletter, psychscenehub.com, but the YouTube channel as well, where we can see this particular video.
Okay.
So any final message for the rest of the people before I wrap up?
Well, for psychiatrists, don't be scared of it. And for GPs, think about it.
No, that's great. Excellent. Thank you so much, Professor Hay. Take care. Bye-bye.
Bye-bye.